afternoon, and thank you for the invitation. I hope I'm going to contribute something. I don't know much about what you guys are so good at, so please don't ask me very specific questions on oculomotor stuff. But I thought it would be good to talk about Alzheimer's disease, mild cognitive impairment, with a little bit of emphasis on biomarkers, especially the ocular biomarkers and other emerging biomarkers, and also in the context of one specific variant of Alzheimer's disease, posterior cortical atrophy. So with Alzheimer's disease, the tricky thing is that really the differential diagnosis changes over time. In very early Alzheimer's disease, we have to differentiate it from normal aging and mild cognitive impairment, and it's a continuum. So we have to develop some kind of cutoff, some kind of diagnostic criteria which will help us differentiate and find those breakpoints on this continuum. And some of the biomarkers have exactly the same problem by having this confounding factor of aging. Now, when somebody gets more demented, in moderate stage of dementia, then the differential diagnosis expands to the other types of dementias. And at that point, sometimes it's really hard to tell how it started, because if you look at the patient, they are globally impaired. On top of it, we have very limited tools because we don't have any specific diagnostic test except pathology. So in a human living person, we can only get to the probabilistic diagnosis level. So when we meet somebody with cognitive decline, there's a wide range of differential diagnosis, including Alzheimer's disease, which is the most common form, and then frontotemporal dementia, vascular dementia, dementia with Lewy bodies, the tauopathies, and then some other entities such as normopressure hydrocephalus and the rapid progressive dementias. One of those is CJD, which is a prion disease. So in order to differentiate between these dementias, we actually develop diagnostic criteria. And what you have to find pertinent positive findings to meet one of the diagnostic criteria. So it's kind of like a puzzle. You have to put all the positives together and exclude all the other pertinent positives. So in Alzheimer's disease, there's a very significant loss of neurons, mostly in the association cortices. And you see on the top pair of images, on the left-hand side, that's a normal brain, same age at the time of autopsy, while on the right side, it's a brain affected by Alzheimer's disease at the same age. You see the marked cortical atrophy. The hippocampus is very atrophied, and there's huge ventricles and extra-axial CSF spaces as well. The pathological hallmarks are amyloid plaques, neurofibrillary tangles, and amyloid angiopathy. And really, to be this smart and know that it's truly Alzheimer's disease at a definite level, we have to do an autopsy. So what we have been using in the field is this is the common denominator for the field, is the NINCDS ADRDA criteria for Alzheimer's disease. And for probable AD, you have to meet the following criteria. There has to be a deficit in 2 or more cognitive domains. And the cognitive domains include memory, language, perceptual skills, attention, constructive abilities, orientation, problem solving, and functional abilities. For these, we use clinical symptoms, cognitive screening tests, and neuropsychological tests to identify the impairment of these cognitive domains. There has to be a progressive decline in memory and the other affected cognitive domain. There has to be present consciousness, the onset between ages 40 and 90, and we have to rule out other systemic brain diseases that could account for the symptoms. So we need to do clinical evaluation again. We have to do imaging and laboratory screen to rule out correctable causes and modifiable risk factors. Now, the 40 to 90 age range is getting a little bit outdated because with the genetic forms of Alzheimer's disease, especially the autosomal dominant forms such as presenilin 1, amyloid precursor protein, and presenilin 2, patients get Alzheimer's disease in their 30s. And also with the, people are aging better, the new 50 is the new 40 kind of thing. Also, older people age better, and we diagnose patients with Alzheimer's disease over the age of 90 because it's still not normal to rapidly forget things.